my talk is on preventing relapse after transplant with targeted agents. And I start by reaffirming that we do not truly have proof that giving a targeted agent after transplant is going to prevent relapse. It should not be assumed that it is beneficial. And for that, we have recent studies out of CML where there was no benefit to giving a TKI after transplant for patients who went to transplant with CML. In addition, many of our targeted agents, while they work quite well in the short term, we do not know what their long-term, any long-term harm might be for simply giving it as maintenance therapy without benefit. So I always want to put out that caution. The two targeted agents I focus on are FLT3 and IDH. Now, the IDH inhibitors, 1 and 2 inhibitors, are being studied in the post-transplant setting to prevent relapse, but those studies are very early on. So we don't really have data on that yet. And then before I talk about FLT3, I do mention that we have some data that administering maintenance type therapies after transplant can delay relapse, and that's from studies with azacitidine in patients who are losing engraftment. And therefore, we have some evidence that the concept is going to work. In addition, we have, with FLT3, we have randomized studies now that indicate that while the long-term survival rate is very good for patients with FLT3 mutated AML going to transplant, I mean, these studies are all showing 60 or 70% long-term survival for everybody. You can improve that with the addition of a FLT3 inhibitor. The point of what we're studying in a very large randomized trial of a FLT3 inhibitor given a FLT3 inhibitor versus placebo administered to patients undergoing transplant is to see if we can find out who benefits. We recognize that 7 out of 10 such patients are not going to benefit from this maintenance therapy. They're not going to relapse with anything. They don't need to worry. We want to identify the ones who are at risk of relapse and preferably apply the maintenance therapy to them.